Good morning, everybody. Today's class is about male reproductive system, part 2. And this is Dr. Sendil. We would like to go into, as we had discussed, about spermatogenesis and the pathway for the traveling of the sperm across with the formation in the seminiferous tubules and how it passes into the rete testis and it is stored there and concentrated and passes on to the epididymis and vas deferens, and how it is brought out through the process of ejaculation. The reason again we are dealing about semen analysis is it is one among the important tests for infertility. And most of the time in the olden days, 1/3 of the causes was from the male partner. So today's class is about semen analysis, abnormal spermatogenesis and male infertility, male sexual act, and the male sex hormone testosterone, its chemistry, actions and mechanism of action, and finally the regulation of male sex hormone functions. Semen is a fluid ejaculated from the male genital tract during orgasm. The normal sperm count, as we discussed yesterday, was 60 to 120 million per ml with a pH of 7.4 to 7.5. It is milky white in color due to prostatic secretion. It is also mucoid. The composition is the sperm is around 10% formed from the seminiferous tubules. The seminal fluid, vesicular fluid, is around 70%, of which fructose provides nutrition to sperms, fibrinogen causes semen to coagulate, prostaglandins help in fertilization of ovum, and seminal vesicular fluid provides the bulk to the sperm. Prostatic fluid is 20%, and the functions are it provides optimum environment by neutralizing the acidic pH of the vagina, helps in clotting of semen by converting fibrinogen into coagulum. The fibrinolysin helps in lysis of coagulum. What are the abnormal forms of spermatogenesis? It can be either oligospermia or azoospermia. If the sperm count is less than 20 million per ml, it is termed as oligospermia. Sperm count below this value leads to infertility. It occurs in 5% of the male population. Azoospermia is absence of sperm. It affects about 1% of male population. It is usually detected during the course of investigation. Abnormal morphology and motility of the sperms can be about 70% of the sperm should be normal morphology. Abnormal sperms in the form of bifid and bifurcated tile. More than 60% of the sperm should have normal forward motility. If the sperms have abnormal morphology and motility, it leads to infertility. As you all know, normally sperms travel at a speed of 3 mm per minute in the female genital tract. The commonest factor, as you all know, the temperature, which should be around 32 degrees, 2 degrees lesser than the body temperature, is very essential. And if you can test the automobile mechanics, the sperm count will be less because of extreme temperatures. And you know what is cryptorchidism? The undescended testis is called as cryptorchidism, which is failure of testis to descend into the scrotum. The testis develops in the abdominal cavity and migrates into the scrotum during fetal development. Under the influence of testosterone, approximately 10% of newborn babies have undescended testis called as cryptorchism, which later descends by the age of 1 year. There is also one thing called as orchitis, which is due to mumps. The treatment of cryptorchidism is administration of gonadotropic or early intervention by surgery by within 1 year. The low count which we discussed about, less than 20 million, and abnormal morphology in the form of bifurcated tail or bifid head, and the motility can be, if it is less than 60%, as you all know, the normal motility should be more than 60%. These are the different forms of head: the pear-shaped head, the double head, the abnormal acrosomal function, or swollen midpiece, or double tail. So this is the abnormal spermatogenesis which we discussed. The next is, what is a male sexual act? The physiology of male sexual act is, it consists of three sequential events like erection, emission, and ejaculation. For any male sexual act, there has to be a neuronal stimulus for performance of male sexual act, for which you need a psychic factor. So the thought, sight, and smell will arouse a male, along with tactile stimulus, which is stimulation of glans penis. The stages of male sexual act are erection, lubrication, emission, and ejaculation. Erection occurs due to dilatation of penile arterioles, causing filling of corpora cavernosa and corpus spongiosum. The penis becomes hard and elongated. Erection of penis is mainly brought about by parasympathetic stimulation through nervi urgentis. These release acetylcholine, vasoactive intestinal peptide, and nitric oxide, leading to vasodilatation. This increases the blood flow, resulting in filling of the erectile tissue. The next is the emission. Emission is a stage where semen moves into the urethra. It is a sympathetic response integrated at L1 and L2. It occurs due to contraction of smooth muscles of seminal vesicles and vas deferens. Ejaculation is a propulsion of semen out of the urethra during orgasm. It occurs due to the contraction of bulbocavernous muscle. It is a spinal reflex integrated at lumbosacral segments of spinal cord. This male sexual act can have erectile dysfunctions or ejaculatory defects. So most of the diabetes in the older age have autonomic dysfunction and results in erectile dysfunction. So you need to know what is semen analysis and male sexual act clinically. And the male sex hormone, as you all know, is testosterone, which is an androgen secreted by testes. They include testosterone, dihydrotestosterone, and androstenedione. Zona reticularis of suprarenal cortex produces androstenedione and dihydroepiandrosterone. These are the male sex steroids: testosterone, dihydroepiandrosterone, androstenedione. Secretion from interstitial cells of lady, also from adrenal cortex. It is steroid in nature, with C19 steroid hormone with hydroxyl group in the 17th position, which is synthesized from cholesterol or acetyl-CoA. The metabolism, it is loosely bound to albumin, that's around 33%, and 65% is tightly bound to testosterone binding globulin, also called as gonadal steroid binding globulin. It circulates around 30 to 60 minutes and gets either bound to receptors and gets degraded into inactive product, that is the androsterone and dihydroepiandrosterone. The rate of testosterone secretion is 4 to 9 mg per day in a normal adult. A small amount is secreted by females, in females by ovaries and adrenal gland. The normal plasma testosterone level in the adult male is 520 nanogram per deciliter. It is degraded to and conjugated in the liver. We would be dealing about the actions of testosterone, which can be androgenic actions and anabolic actions. As you all know, there are two spikes. It is secreted by interstitial cells of Leydig, which forms the 20% compartment of the seminiferous tubules, There are two phases of secretion: 7 to 8 weeks of intrauterine life to 10 weeks of neonatal life. The second phase of secretion is during puberty. The activity of Leydig cells begins at the 7th week of fetal life. The Leydig cells are normally stimulated by HCG, which is human chorionic gonadotrophin, secreted by the placenta. These Leydig cells go into quiescence after the puberty of the child because HCG is no longer available. But at the time of puberty, they again get activated due to LH secretion and continue to function till death. What is the mechanism of action? These hormones, which are steroid hormones, they bind to receptors, the cytoplasm of the target cell. The testosterone or dihydrotestosterone combine with cytoplasmic receptors and the complex migrates to the nucleus. In the nucleus, it binds to DNA and stimulates nuclear proteins. This causes transcription of various genes in DNA, leading to protein synthesis through mRNA. In some target cells, testosterone is converted to dihydrotestosterone by 5-alpha reductase, which is present in nuclear proteins. DHT also binds to the same intracellular receptor as testosterone. This complex is more stable than testosterone receptor complex. Congenital absence of 5-alpha reductase produces male pseudohermaphroditism. These individuals have testes and male internal genitalia, but the external genitalia are that of female. They are brought up as girls at puberty due to action of testosterone. They develop male characteristics, and due to high levels of LH and testosterone, their clitoris enlarges. This condition is called as Penicept 12 syndrome. And 5-alpha reductase inhibitors like fenestride is used in the treatment of benign prostatic hypertrophy. As we discussed, due to the HCG secreted by the placenta, there is a spike of a spurt of increase in testosterone during the intrauterine life, which is essential for the fetal testes to be formed, and during puberty. During 7th week of intrauterine life, there is formation of internal genitalia by the testosterone. After 8th week of intrauterine life, formation of external genitalia by the dihydrotestosterone. Descent of testes takes place during the 7th to 9th month of intrauterine life, which is mainly by the testosterone. There is a male behavior which is developed, which is called as the male psyche, and you all know the boys are all boisterous in nature and they are very aggressive due to testosterone. The second phase, that is during puberty, which is by the influence of LH, it increases the anabolic activity by increasing anabolism and decreasing catabolism. It has actions on internal genitalia by increasing the size of testes and also results in spermiogenesis. That is the conversion of secondary spermatocyte to spermatozoa. The prostate and seminal secretion along with bulbocollateral are increased, and this is mainly due to the action of DHT, that is dihydrotestosterone. On the external genitalia, the length and size of the penis increases. There is increased pigmentation in the scrotum. On the secondary sexual characteristics, there is increased acne. Increased thickness and sebaceous secretion resulting in acne formation at puberty. Hair growth occurs. There is increase in the face, axilla, pubic region, chest, back and margin. There is also a temporal, a male pattern of hair growth in the scalp. Decrease on the scalp is genetically susceptible. The subcutaneous tissue is more rugged. There is increased length and thickness due to increased matrix and minerals. If there is hypersecretion, it can result in fusion of epiphyses. The shoulders are broader with narrow and strong pelvis. The skeletal muscles are 50% more compared to the females. There is deepening of voice, that is, the voice box is lengthened and thickness of vocal cords, resulting in cracking of voice at puberty, which is having a bass quality. In the kidney, it increases reabsorption of sodium, potassium, calcium, phosphate, and sulfate with slight increase in the size of the kidney. It has on the behavior, testosterone causes aggressive and active states and has attraction to opposite sex. It also increases the basal metabolic rate by 5 to 10% at puberty. As you all know, testosterone or the androgens increase the secretion from renal erythropoietic factor and causes increase in RBC or enhances, stimulates the erythropoiesis and erythropoietin secretion. As we all discussed, the control is initially during the intrauterine life, the HCG is secreted by placenta, and later after puberty, it is the LH secretion, that is the luteinizing hormone. The gonadotropin releasing hormone stimulates the anterior pituitary, wherein the luteinizing hormone stimulates the Leydig cells to secrete testosterone, which has androgenic and anabolic action, increasing the protein synthesis. When the levels are more, it causes feedback inhibition of LH and GnRH on the hypothalamus. Whereas the serotonin cells, which enhances the secretion of androgen binding protein, inhibin, and Mullerian regression factor, also has a role by if the sperm is more in number, it causes the secretion of inhibin B, which inhibits FSH, and thereby the spermatogenesis or the serotonin levels are controlled. What are the abnormal secretory states? It can be hypogonadism or hypergonadism or hypotestosteronism. In fetal life, the female sex hormones are formed before puberty. Hypogonadism is due to the absence or deficient testicular function. The causes of hypogonadism are defective development of testis, cryptorchism, absence of HCG in fetal life, and removal of testis. If the condition occurs before puberty, it leads to eunuchadism, where the individuals are tall, thin, and have small genitalia. They have high-pitched voice, narrow shoulders, and small muscle bulk. There is a sparse hair in the body, pubic hair with base of with scalp hair like females. If the testicular deficiency occurs after puberty, there is loss of secondary sexual characteristics, reduced loss, or there is loss of libido, that is the sexual drive, irritability, and depression. Voice does not change much, and there can be hot flushes. Hypergonadism or hypertestosterone results from excessive secretion of male sex hormone, which is caused by testicular tumors. Hypergonadism before puberty results in rapid growth of bones and muscles. There is early fusion of epiphyses and excessive development of sex organs and secondary sexual characteristics. If the condition occurs after puberty, it is difficult to diagnose since the secondary sexual characteristics are already developed. So they can have pocket Hercules, short stature, and after puberty it is difficult to detect, as we discussed. So the functions of testosterone can be revised. It has a differentiation of genital reach into testes and development of male external genitalia. Testosterone is produced around 7th week of intrauterine life. Before 7 weeks of intrauterine life, the gonads are bipotential. The fetus has both Wolffian and Mullerian ducts. Male sex hormone causes genital ridge to secrete testosterone. This causes disappearance of Mullerian duct system and development of male accessory sex organs. Absence of testosterone causes development of Mullerian duct into accessory female sex organs. As we discussed, it helps in the 9th month descent of testis, development of primary and secondary sexual characteristics regarding the distribution of body hair, on the temporal pattern of baldness, on the voice there is deepening and the base quality increases. On the skin it develops into acne. It is anabolic hormone which has, as you all know, the importance of anabolic steroids. These are synthetic substances having anabolic effects, wherein it is used in it is one among the banned substance in athletics. They are banned in sports since they are known to enhance performance. Examples include nandrolone and stanozolone. On BMR it increases, on erythropoiesis it increases the erythropoiesis, on electrolyte and water balance. As you all discussed, the regulation of male female is from the hypothalamus. It has GnRH, the gonadotropin releasing action, which acts through LH and FSH. LH stimulates the Leydig cells which secretes testosterone, which has feedback inhibition, and FSH has a role on the serotoli cells by enhancing the spermatogenesis. And it also has a feedback action through inhibin B. Inhibin is produced by serotoli cells in males and granulosa cells in females. It is a glycoprotein. Its molecular weight is 1 lakh to 10,000 to 30,000. It is made up of two subunits, the alpha and beta subunits. Inhibin helps in regulation of spermatogenesis by causing inhibition of FSH by acting directly on the anterior pituitary gland or acting on, and the second action is it acts on the hypothalamus to inhibit secretion of GnRH. Thank you.